Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article entitled Nivolumab for Relapsed Refractory Classical Hodgkin Lymphoma after failure of autologous hematopoietic cell transplantation. Extended follow-up of the multi-cohort, single-arm Phase II CheckMate 205 trial by Philippe Armand et al. My name is Dr. Andy Evans, and I am Director of the Lymphoma Program and Associate Director for Clinical Services at the Rutgers Cancer Institute of New Jersey in New Brunswick, New Jersey. My oncologic specialty is dedicated to the field of lymphoma. Historically, Hodgkin lymphoma patients who relapse following autologous stem cell transplant have poor outcomes. There remains a continued need to identify safe and effective treatment options for patients in this setting. Important preclinical studies have shown that malignant Hodgkin-Reed-Sternberg cells evade anti-tumor immune responses by several mechanisms, including near-universal genetic alterations at 9p24, which leads to overexpression of the programmed death ligand, PD-L1, on the surface of tumor cells. PD-L1 engages PD-1 receptors on T cells, resulting in inhibition of anti-tumor T cell activity. Nivolumab is a high-affinity, fully human IgG4 monoclonal antibody directed against the PD-1 pathway, resulting in reactivation of T cells and enhanced anti-tumor immune response. Collectively, these data provided strong rationale to examine PD-1 inhibitor therapy in Hodgkin lymphoma. The current study was a large international multi-center single-arm Phase II study that enrolled patients with relapsed or refractory classical Hodgkin lymphoma after failure of autologous stem cell transplant into cohorts by treatment history, namely Cohort A, which was brentuximab vedotin naive patients, or BV, for brentuximab vedotin, Cohort B, BV received after autotransplant, and Cohort C, BV received before and or after autologous transplant. All patients received nivolumab, 3 milligrams per kilogram every 2 weeks until disease progression or unacceptable toxicity. The primary endpoint was objective response rate as assessed by an independent radiology review committee, or IRC. Importantly, patients were allowed to continue treatment beyond investigator-assessed progression as defined by the 2007 International Working Group criteria if protocol predefined criteria were met, which included stable performance status and deriving perceived clinical benefit. Patients treated beyond initial progression were required to discontinue in the event of further progression of equal to or more than 10% further increase in tumor burden. Altogether, 243 patients were treated, 63 in the Cohort A, brentuximab vedotin naive, 80 in Cohort B, brentuximab vedotin after autologous stem cell transplant, and 100 in Cohort C, which was brentuximab vedotin before and or after autologous stem cell transplant. After a median follow-up of 18 months, 40% of patients remained on treatment. In Cohorts A, B, and C, patients had received a median of 32, 32, and 27 doses of nivolumab respectively. The overall response rate by the IRC was 69%, with 16% of patients achieving complete remission. Overall response rates by cohort arm were 65%, 68%, and 73% in cohorts A, B, and C, with complete remission rates in 29%, 13%, and 12% of patients, respectively. Per investigator assessment, overall response rate was 72%, with 33% of patients achieving complete remission, which was slightly higher than the IRC. It should be highlighted that response rates were similar in patients who received brentuximab vedotin before or after autologous transplant, and in patients refractory to their first or last line of therapy. The median time to first objective response was 2.1 months, with median IRC assessed duration of response being 16.6 months overall and 20, 16, and 14.5 months in cohorts A, B, and C, respectively. Duration of response did not differ whether patients were refractory to their first or last line of therapy or to their most recent line of brentuximab vedotin after autologous transplant. The median progression-free survival for all patients was 14.7 months, with 18, 15, and 12 months by cohorts A, B, and C, respectively. The one-year overall survival rate was 92%, without differences by cohort. Overall, 105 patients progressed, of whom 67% were treated past conventional progression, receiving a median of 8 additional doses of nivolumab with a range of 4 to 20 doses, while the other 33% of patients discontinued without further treatment. Of patients with evaluable post-progression data, 61% experienced stable or reduced target tumor burdens, including after the appearance of new lesions. The median duration of treatment past progression was 5.2 months, with 30% of patients still on treatment at database lock. In terms of safety, the most common drug-related adverse events of any grade were fatigue at 23%, diarrhea 15%, and infusion-related reactions at 14%. The most common grade 3-4 drug-related adverse events were lipase increases 5%, neutropenia 3%, and alanine aminotransferase increases 3%. 29 deaths occurred, the most common being due to lymphoma progression at 62%, and none that were considered treatment-related. Overall, only 7% of patients discontinued due to drug-related adverse events, most commonly being pneumonitis 2% and autoimmune hepatitis 1%. The most common immune-mediated adverse events were hypothyroidism, thyroiditis in 12%, all of which were grade 1-2, and rash in 9%, including a handful of grade 3 cases. In addition, 44 patients proceeded to allogeneic stem cell transplant after a median of 13 nivolumab doses. The median time from last nivolumab dose to allogeneic stem cell transplant was 49 days, and the majority of patients received non-myeloablative conditioning. The 6-month cumulative incidence of treatment-related mortality was 13%, while 7% had disease progression. The cumulative 6-month incidence of grade 3-4 acute graft-versus-host disease was 20%, and 15% of patients had chronic graft-versus-host disease. Acknowledging the small numbers, the authors found no clear association between occurrence of treatment-related mortality or grade 3 to 4 acute graft-versus-host disease with nivolumab plasma concentrations. In addition, univariate analysis did not identify associations between the last dose of nivolumab to allogeneic transplant and treatment-related mortality. The 6-month progression-free and overall survival estimates were 82% and 87% respectively. In summary, the CheckMate 205 study of extended follow-up of single-agent nivolumab in patients with relapsed refractory classical Hodgkin lymphoma after failure of autologous transplant showed overall high and durable responses in the majority of patients. Efficacy was seen across varied populations, including patients refractory to prior therapy, including brentuximab vedotin. The study also demonstrated clinical benefit with treatment past conventional progression, which is highly interesting and a potential paradigm-changing concept of drug therapy in the field of lymphoma. In addition, The incidence of acute graft-versus-host disease and treatment-related mortality with allogeneic transplants post-Nivolumab appeared grossly comparable with historical relapse refractory Hodgkin lymphoma cohorts receiving allografts without preceding PD-1 blockade. However, there remains a possibility that prior PD-1 blockade may increase early post-allogeneic transplant toxicity. Furthermore, continued research is needed to more fully harmonize the differences seen in response rates, especially CR rates, between investigators and the IRC. Several recently proposed updates to conventional response criteria, such as LYRIC and RECIL, should be examined closely in this setting. Lastly, longer follow-up and additional experience is warranted to confirm all of the highly encouraging findings reported here, and continued translational studies are needed to identify potential predictive biomarkers of efficacy and safety of checkpoint inhibitor therapy in lymphoma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.